Good evening. Thank you so much for coming. Thank you so much and welcome. We'll get started here. So welcome to tonight's Project Echo session called Ask the Experts, the role of immunotherapy in advancing the treatment of HCC and BTC. This is session 1 of 5, emerging evidence regarding immunotherapy for early HCC. My name is Sarah Bingle-McKillips. I'm with the France Foundation, and I'm your staff facilitator for this evening's session. It's wonderful to see several of you here ready to hear about the latest advances in HCC management. Just before we start, I'd like to just take a brief moment to explain the premise behind Project Echo and our meeting format. So Project Echo stands for Extension for Community Healthcare Outcomes. It's a global movement to share knowledge and expertise across distances. It creates a learning loop where all participants, including our experts and you, can learn from one another. Our sessions are designed to be interactive, so we really encourage you to make the most of this time by asking our presenters any questions you have about your HCC cases. And, so your active participation really makes these sessions truly valuable. Again, thank you so much for being here. I'm really looking forward to tonight's session. And with that, I'm going to hand it over to Dr. Burgoyne.
Thank you, Sarah, and thank you everyone for signing on this evening to participate in this program. There we go. So this is the first of a 5-part series. So this is session number 1, where we're going to be talking about emerging evidence regarding immunotherapy for early HCC. So by way of introduction, my name is Adam Burgoyne. I am a medical oncologist at UC San Diego, and I co-lead our multidisciplinary HCC clinic at the Cancer Center. And I am joined today by my colleague, Dr. Ajmero, who'll let him introduce himself.
Thanks, Adam. I'm Viral Ajmero. I'm an associate professor of medicine here, a transplant hepatologist, and medical director of liver transplant at UC San Diego.
So Dr. Ajmero and I share a lot of patients. So we are happy to walk you through our lay of the land in terms of how we view these early stage HCC patients. I do want to also recognize the planning committee, which you can see shown here on the right-hand side of the slide, which helped for development of the content. And these are our disclosures. All relevant relationships have been mitigated by the France Foundation. And this is an accredited program that allows for CME, which there'll be more information about at the end of this presentation. And we do, of course, want to thank the educational grant support from AstraZeneca for this program to be possible. So objectives of today's session are shown here. Our primary goals after going through the slide deck and today's discussion will be to demonstrate improvabilities to formulate a patient-centered plan for the treatment of early stage HCC while considering patient perspective as well as disease status, to describe the results of key clinical trials investigating novel immunotherapy approaches for early stage HCC, and then finally to develop strategies for effective multidisciplinary communication and coordination. Our agenda is shown here, after the introductions that we've just provided. We're going to talk about early HCC, surveillance and diagnosis, treatment approaches to early stage HCC, providing an overview, and then we'll launch into a bit more details about those modalities: liver transplantation, the emerging role of immunotherapy, resection and ablation, and the emerging role of immunotherapy, how we synthesize all this information in kind of our real-world multidisciplinary tumor boards, and we'll wrap up today's session with some discussion of patient cases. So before we start, we do have a knowledge check pretest question. So if you could all answer this question via the QR code shown on your screen, I will read it aloud. Which of the following best describes the current use of immunotherapy in the treatment of early stage HCC? And our choices are as follows. A, immunotherapy has been approved for use as neoadjuvant therapy before liver transplant. B, immunotherapy has been approved for use as adjuvant therapy after liver transplant. C, neoadjuvant immunotherapy has been shown to reduce recurrence of HCC disease following resection. Or D, adjuvant immunotherapy has been shown to increase recurrence-free survival following HCC resection. I'll give everyone just a minute to answer that question, and then we will move on. All right. Well, we will move into our content then, and I am going to turn things over to Viral to kick us off.
Great, thanks, Adam. So we'll start by discussing who warrants surveillance for hepatocellular carcinoma. Next slide. So based on AASLD guidance, there's two major populations that warrant HCC surveillance. That's patients with cirrhosis, primarily Child-Pugh A and B patients, or Child-Pugh B or Child-Pugh C patients who have more severe liver disease that are awaiting liver transplantation. In addition, a number of non-cirrhotic patients can also be at significant risk for hepatocellular carcinoma. This is primarily patients with chronic hepatitis B infection, mainly through vertical transmission from an endemic country. Based on additional risk factors, we can determine the age at which we should start HCC surveillance. So chronic hepatitis B patients who are male, age 40 or greater, we should be surveilling. Females age 50 or greater, patients from Africa or sub-Saharan Africa in particular have a higher rate of hepatocellular carcinoma. So we start surveillance immediately, and family history is an additional risk factor. Now, how do we surveil these patients? The recommendations are that we use biannual ultrasound and alpha-fetoprotein. Immediately going to contrast-enhanced cross-sectional imaging, including CT and MRI, is not recommended for routine use, although we'll talk about situations in which one may need to use another modality if ultrasound is inadequate. Unfortunately, despite the recommendations, real-world adherence to surveillance recommendations is challenging. Getting patients to be able to adhere to this biannual ultrasound and alpha-fetoprotein, particularly if they're not symptomatic from their disease, is difficult, and adherence rates are less than 25%. Next slide, please. But we do know that surveillance is associated with a number of positive factors, including one, the ability to detect the disease early. Two, then if the disease is detected early, the opportunity for curative therapies, and we'll talk about what those modalities are and how that translates to, in this systematic review and meta-analysis published in 2022, an improvement in survival. So surveillance is critical and important, and certainly we need to improve on its implementation. Next slide. So we mentioned that we should start surveillance with an ultrasound and alpha-fetoprotein, but there are instances in which an ultrasound may be inadequate. In an optimal situation, your radiology group may provide you with a sense of how well they were able to visualize the liver and assess for lesions or nodules. There have been publications on utilizing a scoring system with visualization scores A, B, or C. And then based on the visualization score, if there's poor visualization, you may need to switch to another modality. So visualization score C, one would consider then doing contrast-enhanced MRI or multiphasic CT. Visualization score B, one may repeat the ultrasound in a period of time, or visualization score A with no lesions, repeat in 6 months per general recommendations. If you do detect a lesion that's greater than 1 centimeter, or you have a rising tumor marker, mainly alpha-fetoprotein, you can then switch to a more sensitive modality, contrast-enhanced multiphasic cross-sectional imaging to detect your liver lesion. Next slide. So hepatocellular carcinoma has benefited from truly distinct characteristics on multiphasic cross-sectional CT or MRI. And those characteristics can help us detect and diagnose hepatocellular carcinoma in the right population with high certainty, often obviating the need for a biopsy. So the LIRAD system can help us stratify the likelihood of benignity to malignant potential and potential for being hepatocellular carcinoma in the appropriate population. So this should be patients with cirrhosis or chronic hepatitis B, the patients who we should be surveilling and have a higher pretest probability of hepatocellular carcinoma. Here we can see LIRAD's scoring system going from 1 to 5, with increasing likelihood of being a definite hepatocellular carcinoma to the point where a LIRAD's 5 observation does not require a liver biopsy. There is another category, LIRAD's M, which is a probable malignant lesion, but it's not specific for HCC. In that case, a patient would need a biopsy to distinguish cholangiocarcinoma versus hepatocellular carcinoma or other liver malignancy. Next slide, please. This is an important slide. So if a patient does not have a LIRADS 5 observation and you have a LIRADS 3 or 4 observation, which could be considered indeterminate, what is the actual risk of that observation being a hepatocellular carcinoma? So one shouldn't have false reassurance if you see LIRADS 4 that it's not an HCC. The probability of being an HCC is still 60 to 70%. And the appropriate next step in that situation may be a liver biopsy to confirm the diagnosis or ongoing imaging observation. A LIRADS 3 observation has a 20 to 40% likelihood of being a hepatocellular carcinoma. So oftentimes repeat cross-sectional multiphasic imaging is what's recommended in the appropriate population. And as I mentioned previously, LIRADS M has about a 35% chance of being hepatocellular carcinoma, but 93% of being malignant. So those will need a biopsy for further characterization. Next slide, please. So today we're going to be focusing on early stage hepatocellular carcinoma. So this is the BCLC staging system. You'll see it a few times throughout this presentation. Really, we're looking at either a single hepatocellular carcinoma that's under 2 centimeters, multifocal HCC that is less than 3 centimeters, or we'll also be discussing Milan criteria as it pertains to liver transplantation with a single hepatocellular carcinoma under 5 centimeters. So this is generally our earlier stage hepatocellular carcinoma, and we can see on the bottom some of the treatment modalities we'll discuss, including ablation, resection, and liver transplantation, as well as other local regional therapies. Next slide, please. Importantly, 90% of hepatocellular carcinoma in the United States occurs in patients with underlying cirrhosis. So that's what makes this malignancy particularly dependent on multidisciplinary management with medical oncology, hepatology, as well as surgical oncology or transplant surgery, interventional radiology, and radiology. Certainly, the severity of underlying disease affects the ability to tolerate treatments, and there are a number of complications of liver disease, including encephalopathy, ascites, coagulopathy, that can help stratify the patient's underlying risk. Here we see the Child-Pugh score, which has been longstanding and used to stratify the risk of and severity of underlying liver disease. And you can see a Child-Pugh C patient has extremely high liver-related mortality in the near term, 1 to 2 years. So we have to take those factors into consideration when choosing a treatment modality. Are we addressing the underlying malignancy and potentially the liver dysfunction, or will the treatment modality be tolerated in the setting of severe liver dysfunction? Next slide, please. And I think now I'll hand it back over to Adam to talk about our multidisciplinary approach.
All right, great. Thanks, Viral, for kicking us off. So I will start walking us down some introduction to these treatment approaches for our early stage HCC patients, starting with an overview. As Viral mentioned, we are going to see these different iterations of this BCLC staging system that we use to guide our management for our HCC patients. And one advantage of the BCLC staging system is that it incorporates both tumor-associated factors in terms of where tumors are, if there is how many tumors there are, if there's any evidence of extrahepatic spread or portal venous invasion that would make people advance, but also incorporating patient-derived factors like what is their performance status and what is their liver function. And for those patients that fall into that early stage, you can see here from this box on the left that we actually have a variety of modalities that we can offer to patients, which is all the more reason it is important that we sort of review each case independently and don't overly generalized treatment algorithms for patients, because they can differ based upon patient factors, liver-related function factors, and tumor factors. So what are these modalities? So really some of the big ones that we wanted to highlight today are, number one, ablation. So this is a technique typically done by our interventional radiology colleagues for tumors that are small and accessible percutaneously. The majority of these are done by either radiofrequency or microwave ablation, although other ablative modalities are possible, cryoablation and ethanol. And as I mentioned, this is a percutaneous approach to locally provide definitive therapy for a small lesion. It's typically done by ultrasound or CT guidance. Surgeons, of course, have a very prominent role at the multidisciplinary table for the management of HCC patients, particularly those that have early stage disease. As Viral mentioned, stratifying those patients into those that are either non-cirrhotic or have well-compensated cirrhosis without portal hypertension certainly determines what pathway patients are best suited towards. And those patients that are non-cirrhotic or have limited portal hypertension, resection of curative intent can be an effective treatment for such patients. Obviously, we have the unique treatment option of liver transplant for liver cancer. And, Viral lives and breathes this world every day as a transplant hepatologist. And we're not going to overwhelm everyone with all of the nitty-gritty details of transplant, but just remember, we'll talk a little bit more today that for patients that are good candidates, this can be an option of curative intent for both HCC as well as their underlying liver disease. And just a little note at the bottom of the slide, we're not going to spend too much time on other local therapies such as chemoembolization and radioembolization. We're going to talk about that more in our next session. But even for some early stage patients, that can be appropriate for patients that have single nodules that are less than 8 centimeters. So how do we make these decisions? Obviously, this is guided in part by data in this space, but one caveat of the HCC population is that it is heterogeneous. So we do have to consider a number of characteristics. What's the tumor burden? How many tumors are there? If we have pathological data, is it poorly differentiated, moderately differentiated, well differentiated? What's our recurrence risk? How aggressive is the tumor biology? What's the health of the liver? Is it a cirrhotic liver? Is it a patient that has functional reserve? Is portal hypertension present? These are key factors for us as we're deciding on those modalities because we always need to put patient safety first. What's the overall health of the patient? Unfortunately, with the epidemiology of this disease, with patients presenting often later in life, depending on their comorbidities, those can be challenging as well as we were thinking about these modalities. And then, of course, other patient factors. So are patients actively using alcohol or abusing drugs? Do patients have an adequate support system for complicated treatments like clinical trials or systemic therapy or transplantation? And as Viral alluded to, we have to have a big table with lots of seats at it to get the best care to our HCC patients. And that includes a number of different disciplines. And HCC disciplines are a bit unique in that interventional radiology, for example, plays a large role given that they have both diagnostic and therapeutic abilities to help with HCC patients, transplant surgery, transplant hepatology, medical oncology, diagnostic radiology, pathology, as well as other supportive modalities, palliative care, nutrition, support groups. And we know from a number of studies shown on the right-hand side of the screen that we don't do this just because we think that it provides good patient care. We have data to support that it actually improves HCC patient outcomes when patients are evaluated in multidisciplinary format. So what are our curative therapies in early stage HCC? Obviously, we are always trying to get our patients to cure when possible. And what room do we have for improvement? So unfortunately, only about 30% of patients with HCC are diagnosed at early stage. And those patients, the majority of whom we offer curative therapies, either ablation, resection, or transplant. And those, depending on those modalities, those can have quite long median survival durations, greater than 60 months. Unfortunately, some patients with HCC do recur even after curative intent therapies. As many as 88% who have resection or ablation can recur. It's probably on the higher end of the spectrum, but even after transplant, 10 to 15% of patients can recur post-transplant, despite adhering to current guidelines for appropriate selection of patients. And why does this happen? Well, there's a few different reasons. Just like with any tumor type that we treat with intent for cure, usually with surgery, we do always have this risk, depending upon the disease biology, that there is some amount of micrometastatic disease that was left behind. And then in the absence of adjuvant therapy, that micrometastatic disease can blossom, and then patients can have these early recurrences within the first 2 years after treatment. Somewhat unique to HCC is that for patients that don't undergo transplant, that continue to have a diseased cirrhotic liver that was a setup for their HCC to form in the first place, we can have de novo tumor formation due to that underlying cirrhotic environment that is pro-inflammatory and has all the right setup for a new tumor to grow, even after curative intent for a tumor in another part of the liver. So the question here is, what's our opportunity for improvement? We heard a talk tonight a bit about how immunotherapy has transformed the landscape of really all of oncology, including HCC, mostly in the advanced setting. But as we are learning more about the role of immunotherapy in the advanced setting, we're starting to bring it into earlier lines of therapy to see if it can improve outcomes. So can we use things like neoadjuvant or adjuvant immunotherapy to delay or reduce HCC recurrence following resection or ablation? And then interestingly, can we incorporate immunotherapy in our transplant algorithms? Can we downstage patients to transplant to get more patients closer to curative intent therapies? So along the line, I will turn things back over to Dr. Ajmera to talk about transplant.
Great. So thank you, Adam. I think as we dive into this topic, we want to hit on I want to reiterate 2 points Adam made. One is that even if we address, let's say, a single or 2 foci of hepatocellular carcinoma in a cirrhotic liver, the underlying milieu is still predisposed to form additional HCCs, in addition to the risk of a local recurrence. So that's part of why we see such a high rate of recurrence. And then the second factor is that patients, while awaiting transplant, may no longer be candidates due to their tumor biology becoming more aggressive and moving out of criteria. And so those are some of the opportunities to start thinking about, is there a role for immunotherapy? And we're in very early days, but we're going to share with you some of the data and the background and the framework with which we're approaching this challenge to improve patient outcomes. Next slide, please. So the history of HCC and liver transplantation is long. I could take the full hour discussing this, but I won't. But this was a seminal paper by Mazzaferro and colleagues, really getting just right the amount of tumor burden that allows one to derive a significant mortality benefit from liver transplantation without an extremely high rate of recurrence after liver transplant. And the Milan criteria has really stood the test of time. We've iterated and added to it, but it's still an important general framework for patients who have HCC who may be considered for transplantation. So this is one foci of HCC that's less than or equal to 5 centimeters, or you can have multiple nodules, 2 to 3, under 3. And so that is the Milan criteria. And here demonstrating, almost 30 years ago, excellent post-transplant recurrence-free survival if you stick to those criteria. Next slide, please. But of course, if people can do well within Milan criteria, the question is, what happens when you go beyond Milan criteria? And now, again, there's been a number of publications evaluating this. This is a nice summary slide. We know that UCSF criteria existed and pushed us slightly beyond Milan. And now, more recently, downstaging criteria have been adopted formally into transplant protocols and policies in the United States, such that you could have a patient who is beyond Milan criteria in what we call downstaging criteria. They can have a single HCC up to 8 centimeters, 2 to 3 that are slightly larger, bigger than 3, but less than 5, and a total tumor diameter less than 8, or 4 to 5 that are all small, less than 3, and total tumor less than 8. So even the hepatology fellows have a hard time remembering this. It's not important to remember the exact criteria, but the key framework is if you go beyond Milan criteria, but you are able to downstage the patients using some of the modalities that Adam talked about and which future sessions will go into deeper detail on, then patients can have excellent outcomes. Next slide, please. So this is some European data looking at patients beyond Milan criteria and then getting downstage with either local regional therapy or in some cases, it's a combination with other systemic therapies, and demonstrating that this population can do very well with transplant. There's also US data from UNOS demonstrating the same thing, that you, within downstaging criteria, can get about 79% 3-year recurrence-free survival. Again, going beyond Milan criteria and still doing well. There's some emerging data now about the safety of immunotherapy in this downstaging time frame. Now, we have very limited data about actual efficacy. The first question is really as it relates to safety. Next slide, please. So this is a Chinese study including 83 patients at 11 different centers. And these are patients who received immunotherapy. And what we see as a key highlight is the overall outcomes still look excellent, but there's an increased risk of rejection. And that completely makes sense. And many of these patients had received their last dose of immunotherapy within 30 days of liver transplantation. I'll tell you that the US experience, which we've also published on, and there are many emerging papers coming now, has also demonstrated that time from last dose of immunotherapy to transplant is a critical factor in terms of preventing post-transplant graft loss from severe rejection. And in US data, really somewhere between that 1 and 3 month washout period is critical to mitigate the risk of rejection and critical rejection after liver transplantation. And really, if, from the US data, if you wait 90 days, there's no severe or significant rejection in emerging publications. So the first piece is, can it be safe? And then the next step is really creating the studies to evaluate its efficacy in the ideal population to incorporate immunotherapy pre-transplant. And that is still something that's being actively investigated. Next slide, please. Okay, I'll pass it back to Adam to talk a little bit about the role of resection ablation in immunotherapy.
All right, great. Thanks, Viral. Certainly an exciting time that we are in as we are starting to marry this concept of the use of immunotherapy and transplant. Still lots to learn, but we are in a rapidly moving space. So as I said, an exciting time. So again, just to anchor us back to BCLC staging system, as I mentioned, we are talking about early stage patients today. So those are the very early stage single small tumors or early stage BCLC stage A patients. And, you know, we've talked a bit about ablation. Oops. We've talked a bit about ablation and resection and transplant. How do we think about bringing immunotherapy into this space? Well, there's really a few different strategies that we think of if we just use HCC as an example of textbook oncology. So, you know, when we think about textbook oncology, are there neoadjuvant strategies that we can use to shrink tumors to make surgical resection more feasible, less morbid, reduce risk of recurrence? Or are there adjuvant strategies that we can use after therapies such as ablation or resection of curative intent to prevent recurrence of cancer? And really, at the immunotherapy level, we're thinking about two sort of different approaches. So in the neoadjuvant space, we're thinking about intact tumors that still have an immunostimulatory effect and that we can use neoadjuvant immunotherapy to interact with the tumor microenvironment and perhaps have a pro-inflammatory effect and lead to hopefully tumor necrosis and tumor death. Adjuvantly, we are thinking about using immunotherapy to treat patients, again, after complete resection or ablation to treat that micrometastatic disease effectively. And our hope is that the adjuvant immunotherapy can boost the immune system to clean up any of those residual cells to prevent recurrence. So I want to talk about the most mature data first, which is the IMbrave050 study. So this was a large global phase 3 study of patients after resection or ablation of curative intent that were randomized to receive either 12 months or 1 year of adjuvant immunotherapy with atezolizumab targeting PD-L1 in combination with bevacizumab targeting VEGF versus active surveillance. And the patients were defined as high risk if they had one of the following high-risk features. So that was tumor greater than 5 centimeters, more than 3 tumors, the presence of vascular invasion, or high-grade, grade 3 or 4 pathology. And after randomization, patients received 1 year of therapy, 12 months or 17 cycles versus surveillance. And the primary endpoint of this study was recurrence free survival. And patients were allowed to cross over in the active surveillance arm. You can see here the top-line data, the curve here. This still is quite immature, although it has been both presented in major conference format and published in Lancet last year. So this is the recurrence-free survival curve. The blue curve on the top is the atezo-bev curve. You can see here there's an early separation at the 12-month mark. The RFS event-free rate was 78% for atezo-bev versus 65% for the active surveillance. Somewhat alarmingly, the curves do seem to converge at these later time points. So there is a question on how this will translate into the overall survival benefit, and if this is just delaying recurrence, but not necessarily truly curing patients. Nevertheless, this was a positive study. You can see here that at this early data cutoff, although the median was not reached for either arm, the hazard ratio was positive, 0.02 with a statistically significant p-value, suggesting that atezo-bev can decrease recurrence rates for HCC patients treated with intent for a cure that are high risk of recurrence. What about safety? Obviously, as medical oncologists, we tend to think of our medications as having, quote unquote, acceptable safety profiles. I think that's a bit more important in the advanced setting where we know that patients have terminal malignancies and we can tolerate a bit of toxicity if it's going to lead to an improved outcome. Here, I think we do need to be a bit more careful, although the immunotherapy signal and the bevacizumab safety signals are very well characterized as of 2024. There were some high-grade events in the atezo-bev arm. There were some grade 5 events in the atezo-bev arm. So although this is exciting early data, we really still are waiting on more mature data cutoffs and, of course, that OS data that will ultimately help us understand if adjuvant immunotherapy truly leads to improvement in survival. This is not the only study in this space. There are a number of other immunotherapy strategies and immunotherapy combination strategies. So we just talked about atezo-bev. There is a pembro versus placebo trial. There is a nivo versus placebo trial. There is a durva-bev versus placebo trial. And there is a teripalimab versus placebo Chinese study as well. All of these studies are actually getting fairly mature. So I anticipate some of this data will be reading out relatively soon. So stay tuned for this space. I want to touch just very briefly on the concept of neoadjuvant therapy. There are a number of small studies that have been published that are hypothesis generating and encouraging, showing that different combinations of nivolumab monotherapy or dual immune checkpoint blockade with nivolumab plus ipilimumab or other single-arm checkpoint inhibitors can lead to major pathologic responses. So in the nivo and ipi-nivo study, 6 out of 20 major pathologic responses, and 5 out of those 6 patients had complete responses. And those patients that responded really well to immunotherapy neoadjuvantly had really good long-term outcomes, 0 recurrences after 24 months. So again, early data, encouraging data. I think more work needs to be done in this space. Larger trials need to be done in this space. But perhaps a role for immunotherapy in both the neoadjuvant and adjuvant settings. So that brings us to the end of our slide deck of content. So I did just want to loop back to our knowledge check from our initial question. So if you want to get your QR codes back out, which of the following best describes current use of immunotherapy in the treatment of early stage HCC? A, it's been approved for use as neoadjuvant therapy before liver transplant. B, it's been approved for use as adjuvant therapy after liver transplant. C, neoadjuvant immunotherapy has been shown to reduce recurrence of HCC disease following resection. Or D, adjuvant immunotherapy has been shown to increase recurrence-free survival following HCC resection. And it looks like Sarah put in a link if you're having trouble with the QR code. Okay. Well, thought we would move on with to conclude the evening with some case examples. And we can do this sort of one of two ways. I think that you were all tasked with perhaps providing a case if you had something that you were interested in talking about and bringing to this group. Viral and I are happy to walk through those cases. We have some cases we can talk about as well. And really the highlights that we wanted to discuss today was the importance of these multidisciplinary discussions that we have, either in a multi-tumor board or in collaborative groups. Are we talking about transplant, resection, ablation? What are our consideration for these modalities, disease status, specific characteristics of patients, patient perspectives? Is there a role for neoadjuvant or adjuvant therapy? How would it benefit patients? Are there trial opportunities for this patients? How can we help connect people with trials? So those are some of the things that we think about when we're talking about management of our early stage patients. And Dr. Edgemere and I just came from liver tumor board, so this is fresh on our minds. We're ready to tackle cases. Does anybody have a case they wanted to talk about? No takers? Okay. Well, if you think of one, we will start with a case here. Viral, do you want to kick us off?
Sure. So this is 54-year-old gentleman who had hepatitis C and achieved a sustained virologic response. Importantly, the patient likely had underlying cirrhosis, and so that person still needs surveillance for HCC. They're still at risk for developing it, and are ultimately found to have a 3.6 centimeter LIRADS-5 on imaging. LIRADS-5 is a definite hepatocellular carcinoma. If the patient does have underlying cirrhosis from HCC, then it's an appropriate application of the LIRAD system. So we always have to incorporate details about their underlying liver disease. And here we see this patient has compensated cirrhosis, no portal hypertension on imaging, their Child-Pugh A, you can see their labs there. Platelet count is 110,000. Alpha fetoprotein is elevated at 42, mildly elevated, good performance status. So Adam, certainly I can comment on the underlying liver disease. What are your thoughts on the diagnosis here and additional information you would want or treatment recommendations you'd have?
Yeah, I mean, I think one question that comes up a lot for cases like this in a person that, as you mentioned, is known cirrhotic is, do we need to do any more diagnostic workup, right? So we have an LR5 based upon our multiphasic imaging. Do we need to do a biopsy here?
With the LIRADS-5, in this instance, there's no need for a biopsy if it's an appropriate population. Now, if this person didn't have underlying cirrhosis, then a biopsy would be indicated because it affects the pretest probability and the application of the LIRAD system. We don't see evidence of portal hypertension, which is an important factor in terms of thinking about the treatment modality as well. But I think from a diagnostic perspective, multiphasic cross-sectional imaging, assuming it was truly multiphasic and adequately timed, and there's a LIRADS-5 observation, I don't think we need a biopsy for this patient.
Yeah, I agree. As a medical oncologist, I'll never turn down tissue, but from a pure diagnostic perspective for this person, they've got a unifocal tumor that we can hopefully treat with curative intent. No need to introduce the additional risk of a biopsy, although a rather small risk, but if it's not necessary, we don't need to pursue it here. So I agree. We have our diagnosis. And, for someone like this, we don't have our interventional radiology colleagues on the line, at least from UCSD, so we can speak on their behalf. 3.6 centimeters, probably too big for an ablation, although some of the Asian population would push that boundary a bit. And then in a person that is compensated without portal hypertension on imaging, although the platelets are a bit on the lower side, I think that we always need to think about what's the best way to get this person to treatment with intent for a cure. So from my perspective, we would want to make sure that our surgical colleagues evaluated this patient to see if they would be a candidate for upfront resection.
Completely agree. I think the platelet count is the one factor that gave me pause as well. Platelet count under 150,000. Even in the absence of overt evidence of portal hypertension on imaging, it still makes me concerned. We don't see any commentary here about an upper endoscopy to look for varices, although there's none on imaging, but to look for mucosal varices. In this instance, oftentimes at our program, we would get transjugular portal pressure measurements to ensure the absence of clinically significant portal hypertension before proceeding with a resection. In this case, the patient may be an appropriate candidate for resection, but I would obtain that reassurance from our IR colleagues and ensure that there is an absence of clinically significant portal hypertension before a resection. This is 3.6 centimeters. We don't know exactly where in the liver it is, so we can't comment on exactly how much liver tissue will need to be resected, but that would be an important step that most of our surgical colleagues would obtain, particularly with a slightly lower platelet count.
Yeah. What about transplant?
So I think this has to do with what is the most appropriate step if it is in fact resectable based on location and they do have an absence of clinically significant portal hypertension. Moving straight to resection is reasonable. We talked about the high rates of recurrence after resection, but if you compare resection and transplantation in an intention to treat approach, then some of the long-term outcomes are more comparable because transplantation requires a rigorous workup. Not everyone is a candidate, and we'll talk about some of the psychosocial factors like social support, free from any polysubstance use, and other medical comorbidities that could disqualify a patient from transplant, but they still may be a candidate for resection. So I think in this case, if we confirm the absence of clinically significant portal hypertension and it's in a good location for a resection, that's reasonable. Sometimes we have tumors that are in very unfavorable locations for a resection, and even in the absence of clinically significant portal hypertension, we consider transplant in those cases.
Yeah. And then just to kind of complete our discussion, typically no role outside of a clinical trial for systemic therapy in a patient like this that has early stage disease. That being said, if there was this person looks like a good potentially clinical trial candidate on paper. So if there was a good neoadjuvant study, this would be a potential person to consider the use of immunotherapy in a neoadjuvant clinical trial, because it's this type of patient that helps us understand that this person, who although is upfront resectable and doesn't need to be downstage or converted to resectability, perhaps there would be a role in prevention of recurrence from neoadjuvant immunotherapy. But again, those are really research questions in 2024 in terms of if that's going to truly improve outcomes.
Mm-hmm. Great. Any questions from the audience? Okay, so here we see the outcome of this case. Patient ultimately pursues surgical resection and does well and doesn't decompensate in the early postoperative period and is discharged. So they were able to undergo resection with curative intent. Adam, so would you offer this person immunotherapy after resection?
Good question. I think as we have this IMbrave 050 data, it's certainly something that is coming up more often. To be, clear and transparent, this is a positive study. This does not carry an FDA approval yet for this indication. Atezobev is approved for HCC and other settings, so it is a regimen that we can often access off-label if we are worried about a patient. You will get different answers from different medical oncologists about how widely they're embracing adjuvant immunotherapy. From my perspective, this case is a bit more straightforward. This person would have not met eligibility criteria for IMbrave 050. They're not high risk enough. Their tumor's too small. We don't have all the path data. But, presuming that this was not a, grade 3 or 4 tumor, that there was no surprise vascular invasion or satellite lesions, this person is going to be on the lower risk end of the spectrum for recurrence. And as of 2024, we don't have great data that any kind of treatment beyond close surveillance will improve outcomes.
Great. Yeah, I think it's an interesting area. If this patient did have lymphovascular invasion on their resection specimen, would you revisit that, or would bump up their risk of recurrence?
Yeah, if this person did have a higher risk feature on their pathology report, I think it is worth a discussion. That for me becomes much more of a shared decision-making kind of a discussion, particularly with a patient that's engaged and savvy. This person's only 54 years old. They potentially have a substantial amount of life ahead of them. If they're highly motivated, if they're engaged, and they're willing to undergo that sort of intense treatment of 1 year of adjuvant therapy and assume that risk of a complication is not zero, but there's a potential benefit there for decreasing their risk of recurrence. Again, this is a patient that has a higher risk feature. It is a discussion that I am having with select patients.
Great. Yeah. No, it's very dynamic. So I think it's exciting to have these conversations, and every 6 months they're evolving in our tumor board, right? So
Exactly.
Even a straightforward case can become a little bit more complicated. But any other questions to wrap up case 1 from any of the attendees? If not, I think we'll have time for a second case.
Yeah. I can kick us off on this one if you want.
Great.
So Mr. Smith is a 62-year-old man, alcohol-associated cirrhosis, now abstinent, complicated by well-controlled ascites. He's found to have a liver lesion on surveillance imaging. It's unifocal with max diameter of 2.1 centimeters. Our radiology colleagues tell us that it's an LR4. His ascites is considered to be well-controlled. He does not have hepatic encephalopathy. He is child PUB. You can see his labs here. Bilirubin is 0.7, albumin 3.2, INR1. Platelet count 72,000, AFP mildly elevated at 27, and his performance status is good, ECOG 0. So a slightly different case than our first one, a bit more complicated. Always glad to have a hepatologist on the call to help for these patients that their liver function's a bit borderline. Viral, how would you think about a patient like this?
Right. This is unfortunately a very common situation that we encounter. I think the alcohol-associated liver disease can make liver function more dynamic. So, many liver diseases are considered gradually progressive and don't regress. I mean, if you cure viral hepatitis or treat it and control it, you may have some recompensation. And we certainly see that with alcohol. So this person is now abstinent. We don't know how long they've abstained from alcohol, but certainly we see improvement in liver function for the ensuing 6 to 12 months after stopping alcohol completely. And in many patients, they can recompensate. So now this person has ascites they can control with medications, but their child PUB, you can see their albumin is lower at 3.2, platelet count is lower, indicating likely more portal hypertension. And so this becomes a patient where transplant and an opportunity to cure both the underlying HCC as well as the underlying liver disease, which is advanced and has significant morbidity and mortality associated with it, becomes potentially an optimal option. One thing I noticed here is the patient has cirrhosis, so we can use LIRADS, but this observation is called a LIRADS 4. So going back to our earlier slides, maybe that's a 70% or so probability of being HCC, not definitive. So Adam, in this case, what would you recommend with the LIRADS 4 observation here?
Well, I mean, technically, we don't have a diagnosis of HCC, right? LIRADS is a great imaging tool that we have, and when it's a slam dunk based upon the imaging that it's an LR5, and we can diagnostically, with certainty and in that at-risk population, avoid a biopsy because our imaging diagnosis is high enough quality. That's great. This person's not quite there. So additionally, if we are thinking about transplant, what would UNOS feel about our diagnosis here?
Right. So one can't get the exception points that increase your priority for transplant unless it's a LIRADS 5 observation or a biopsy-proven HCC. So this is a really critical point. If you don't have definitive HCC based on a LIRADS 5 with good imaging, then you still need to biopsy that observation. Otherwise, if you treat it and then refer them to transplant, we wouldn't be able to obtain priority on the wait list that patients with HCC can get if they're within Milan criteria, because it's not considered that they have a definitive diagnosis. And if, let's say, you ablate this observation and it's completely dead by the time they're referred to a transplant center, we have no opportunity to prove that it was originally an HCC definitively. So biopsy is really critical if this patient may be a transplant candidate.
Absolutely.
And then,
go ahead.
In terms of liver function, I mean, although this person's liver function is a little bit worse, they likely would still tolerate local regional therapy, and ablation or other modality would be reasonable. It's a 2.1 centimeter observation. So even if you're considering transplant, you still want to control the HCC, because we didn't talk a lot about the logistics, but essentially they get exception points and increased priority for transplant only after they've been on the waiting list for 6 months. So it's not, the clock for patients doesn't start when they're diagnosed with HCC. Unfortunately, it only starts after they've been added to the waiting list. So there may be a long latency period that can vary regionally, and we want to control this HCC and not let it grow while we're waiting for a curative transplant.
Absolutely. So you alluded to kind of our most likely treatment algorithm, which would be to proceed with local regional therapy. Again, many centers, given the size, would think about a percutaneous ablation. Patients love 2-for-1 specials. So, one advantage of that strategy would be sometimes even considering biopsy and ablate at the same time, which is a practice that we do in some patients when it's appropriate, given that both procedures are done percutaneously with the same approach. What about systemic therapy here? I think with a lesion of this size, it's really hard to make a case that we need anything on top of local regional therapy. I think we need to be careful about overtreatment, of course, in this population. I do think that probably would be overkill in my book with this amount of disease, which is quite minimal at this point. And then the other, I would say, very key point that we need to consider is if we're walking this person towards transplant, we need to be, thoughtful about, again, not overtreating, not introducing more variables that might make their transplant course more complicated. Although, as Dr. Edgemere, just explained and went through the data, it seems like it is safe in the majority of patients, but don't introduce a new problem if we don't need it, and we can get by with local regional therapy alone would typically be the approach that we would take.
Agreed. This patient has a very low risk of waitlist dropout from their tumor burden. So it's very unlikely that their tumor is going to grow beyond criteria for transplantation or not be able to be controlled with local regional therapy. So, like you said, we're always weighing the risks and the benefit. Now, if they had a much larger tumor or a tumor with aggressive features, that's really where we're exploring the role for immunotherapy or other therapies combined to get patients to transplant and control their tumor. So I think that's an important point here.
Any questions from the audience on this case? Well, we can walk through the follow-up. As promised, the patient underwent a biopsy, which showed a well-differentiated HCC. One important point that I think Viral alluded to is we should always be doing all of these things in tandem, which is easy in a multidisciplinary format, but if not, making sure that all those referrals are going to the right places. So referring to IR for biopsy, referring to the transplant team for transplant eval, getting that bridging therapy done with the local ablation. And then this person ended up undergoing a living donor liver transplant. Viral, do you want to comment on that pathway a bit?
Sure. Yeah, it's so the standard pathway for a deceased donor requires a 6-month waiting period from the time one is listed and within Milan criteria to the time at which one gets MELD exception points. If you have a living donor, one can just schedule the transplant if you have an appropriate donor. So it obviates the need for that latency period. Although the reason that the governing bodies incorporated that is based on data, because it's useful to watch tumor biology for more aggressive tumors that may be excluded, and because they have a high risk of recurrence. But living donor liver transplantation is an excellent option for patients, and it removes some of the uncertainty with regards to timing.
Great. Any other questions from our attendees today? Oh, I see someone has their hand up. Go ahead.
All right. So hello, everyone. First of all, thank you so much, Dr. Adam and Dr. Vero for this session. It's already 3 a.m. here in Morocco, and I'm very pleased to be part of it today. So I'll be introducing myself. I'm Zakaria. I'm a researcher in immunology and also hematology. Specifically, I'm working in the Ministry of Health of Morocco and also International University Hospital Sheikh Khalifa in Casablanca. So this is just a question to drive a perspective together. So we already know that currently immunotherapy is very, very expensive, and especially that's like when it comes to the patients that are having, for example, carcinoma, and also they are suffering from immunodeficiency. What can be other strategies that we can have, especially that there is a lot of developing countries that still does not have this access to this treatments.
It's a great question. Since you posed the immunotherapy piece, I can take that first. Immunotherapies are very expensive. There's really just kind of no getting around that. And, as we think about using them wisely and appropriately, that is always a consideration. We are fortunate in the United States that if an immunotherapy carries a FDA indication, the majority of the time we can get patients access to that medicine through their insurance or through other programs. In more resource-limited environments, for advanced patients, which we're not really talking about today, things get trickier. I would say, fortunately, that for some of these earlier stage patients, a lot of these modalities are cheaper, percutaneous ablation, for example, or surgical resection. Obviously that requires some degree of infrastructure for the hospital system, but it's a tough balance. And I don't know, Viral, if you have any comments on organ allocation worldwide from the transplant perspective.
I think it's resource limited globally, and there are areas where it's even more limited than others. From a synergistic perspective about how we manage these patients, I think we really have to be thoughtful about what provides the greatest mortality benefit and demonstrate that, and then focus resources there and away from things that provide potentially marginal benefit, like giving someone with a 2.1 centimeter HCC immunotherapy is not likely to have a significant benefit with a significant cost associated with it. But someone with satellotosis, a more aggressive tumor that's evolving, really health systems that should prioritize those patients. And that's just an approach within a resource constrained system so that the people with greatest need and greatest benefit receive the treatments.
Great question. Other questions from the group? Well, we want to be respectful of time. I think we are right at 7, so I will turn things back over to Sarah for a close, but I just want to thank everyone for their attention. It was a great session, and really enjoyed speaking with everybody.
Yes, thank you. Dr. Burgoyne, would you mind going just to that final slide with the sort of next steps QR codes? So thank you so much, everyone. I'll follow up over email as well as we get to this slide. So you can claim your CME, of course. Please scan this QR code here. Also, something that's part of ECHO sessions are these action plans. So they're designed to help you think about how you're going to integrate the new knowledge from this session into your practice. And so it asks you a variety of questions about this and to consider any barriers that you face. As far as future sessions go, this is one of just a series of 5 meetings, and we'd love to see you register at some more. There's a variety of dates and times that you can choose from between now and December, and that registration page is there at the bottom. Again, thank you so much for coming tonight. Thank you for to both of our presenters for this really engaging discussion. And I hope you all have a great evening. And I'll see you at another Hepatic Echo session.